was close.
Well, good morning, everyone. This is Larry Boris. I'm the Executive Director of the National Association of Worksite Health Centers. I want to welcome you to this month's program, Incentivizing Patients and Providers for Better Healthcare Outcomes and Lower Costs. This program is an opportunity for you to learn about an award-winning and well-recognized, and you'll soon hear peer-reviewed service called MedIncentive. That was created a number of years ago when I was actually a coalition director of the Midwest Business Group on Health in Chicago, and first learned about it and its founders. And I'd always been impressed by the potential of this program to really take advantage of a dual, or I think you'll call it a triple accountability approach. So it's not just one party, but it includes the patients and the physician and the employer to be part of an effort to increase the ability of people to understand and self-manage their own care, and to really be incentivized on both ends. And they have the physicians incentivized beyond just the health plan reimbursement. So with that, let's go to the next slide. So for those who may not be familiar, NAWHC, National Association of Worksite Health Centers, is the nation's only organization devoted to on-site, near-site, mobile, and virtual health care for covered populations. We are primarily an employer and union purchaser organization, but we do include all of our service member partners and others that support employer centers. We provide benchmarking services, education, and networking programs like this, etc. Over 100 organizations are members of NAWHC, and we hope you'll consider joining us at our annual meeting September 8th and 9th in Nashville, Tennessee, where we'll be celebrating our 10 years and talking about the future and directions of worksite centers. Next slide. So these are some of the upcoming programs. Next month, we'll have a session on behavioral health services and innovations in worksite centers. May 17th, we'll be talking about the implementation stage for new worksite center. And as I said, the annual forum. Next slide. So with that, I'll turn the program over to Jeff Green, founder and CEO of MedIncentive, for his personal introduction, and he'll take control of the ship. So back to you, Jeff. Thank you again.
Thank you, Larry. Hello, everyone. I am Jeff Green, and I am joined today by Jim Dempster. He's going to help me with a couple of the slides, but this is a very important event for us. We are sharing for the first time what we believe is a seminal study on the application of aligned incentives and the use of something called information therapy. And once I get done, I'm anxious to get your feedback. So this is kind of an opportunity for us to share what it is that we do, share with you the studies and the most recent study on what is really a completely different approach to improving health and lowering costs. So a little bit about my background. I'm an industrial engineer, human factors engineer. I cut my teeth in manufacturing and then ended up in healthcare. And before I knew it, I was teaching practice management to third-year residents at the Health Science Center. And while I was doing that, I built one of the largest practice management billing companies in the country. And I was in high demand, helping doctors learn how to make more money in their practices. And my business grew, and I guess my most important credential is that I eventually became a self-insured business owner. And so I'm looking at the world from this really peculiar point of view, where I understood how doctors and healthcare make money, and I was involved in that, and then I became self-insured. So I came up with an idea. It's called the Trilateral Health Accountability Model, for which I now hold 4 patents, 3 US patents and a Canadian patent. And that's what I'm going to share with you today. And to begin my presentation, I think it's best to try to go back in time and talk about the kinds of things that we've attempted to use or employ to control costs, to improve health and control cost. And I've kind of listed them here. And the one thing that we notice is that the focus seems to be on re-engineering care and controlling price. And the missing element, as far as we're concerned, is a focus on helping patients better self-manage their health. And I would suggest something like financially incenting both the doctor and the patient to tap into their relationship, to educate and inspire patients to be able to self-manage their health. And I go back to my manufacturing days, and I recall being schooled on industrial psychology, Maslow, Pavlov, Hawthorne, Theory X, Theory Y, all these motivational theories that are now in some cases a century old, proven time and time again. And I noted that in medicine, doctors are not taught these concepts, and they are not practiced in the delivery of care. And so what I'm trying to express to you or explain to you is that this is a important missing ingredient in terms of improving health and lowering cost, that we would characterize as the difference between managing patients versus empowering patients. And if you think about it for a little bit, there's a great big difference between these two approaches. So the program is called MATE. It's a patented web-based service that dramatically decreases utilization because it couples financial incentives with this industrial psychology, psychosocial motivators to drive a change in patient behavior that has been proven time and again to improve health and lower costs. Patients are rewarded, or I should say physicians are rewarded for prescribing something called information therapy. It's defined as providing the right information at the right time in the right way, so the patient is better educated and motivated to self-manage their health. It rewards patients for demonstrating and understanding their condition and declaring adherence to treatments. It uses aligned financial incentives to leverage the doctor-patient relationship to improve care and health behaviors through something called mutual accountability. So information therapy and mutual accountability. And to give you a sense for how effective the program is, in a self-insured population over a 5-year period of time, after the program was implemented, the 3-year average of hospitalization rates relative to the 2 years prior to implementation dropped 32%, ER visits dropped 14%, per capita expenditures dropped 11%, producing a 7-to-1 ROI. And again, this is a peer-reviewed, certified study, and I'm going to describe it a little bit later in conjunction with the randomized control trial, which we are introducing for the first time today. So in terms of the doctor's experience, it begins with the patient, a covered patient, presenting themselves for an office visit. So the event that initiates the process is an office visit. The doctor is notified that the patient's covered either by the patient or by notification, either email or fax. And when the doctor is notified, if he or she chooses to participate, they access the website and enter the diagnoses for the patient. That can be done either through an EMR or directly through the internet or by filing an insurance claim. Either which way, eventually the system gets the diagnoses and presents a list of articles in relevancy order to that diagnosis. And the doctor simply selects an article as homework for the patient, and he or she is done. Fast, easy, and it can be delegated to staff. So in large installations, we've seen nurse educators perform this very simple function that takes about 30 seconds per patient. And as a result of selecting an article as homework, the patient automatically receives a notice at home. It's called an information therapy prescription, and the doctor is paid up to $15. So in terms of time and effort, it is one of the most lucrative things that the doctor can do in clinic. So we often get the question, well, what happens if doctors don't participate? Does the program still work? And the answer is yes, and I'm going to explain how that is accomplished in just a minute. The patient's experience begins at home. They receive a letter or an email that directs them to the website, telling them that they can earn a financial reward. Once online, they are presented the article that, again, is relevant to their diagnosis, in this case, hypertension. Content is supplied by vendors like HealthWise, written at the 5th grade level. The next step is a first in medical history. The patient is asked to take a literacy test to demonstrate and document their understanding. Now, it's open book, so no one fails, but it's an important step that closes, I'll use an engineering term, a feedback loop that has been missing from the beginning of time, and that our doctors don't know really what we know, except for the fact that we're nodding our heads until someone assesses what we know, and that is documented. And that's what the system in the program does. Another first in medical history is that the patient is then asked to declare their adherence. Yes, I'm going to follow the recommendations, or I'm not going to follow the recommendations. And then the program lists the reasons why not, such as I can't afford it. It makes me feel bad. I don't think it's effective. I think my doctor got my diagnoses wrong. I'm being overtreated, undertreated, or I just don't want to do it, whatever the reason might be. And again, it closes an important feedback loop. When the patient declares adherence, it invokes something called promise keeping and guilt aversion, an important psychology that nudges a person's behavior. The next step is that the patient must agree to allow their physicians to see their responses, their literacy score, and their declaration of adherence, whether their doctors participated or not. And this is an important step because it invokes something called the Hawthorne effect, which teaches that in the presence of an authority figure, we're in our best behavior, especially if that authority figure is someone that we trust and respect, like our doctor. And then the final step is that the tables are turned and the patient is asked to rate the doctor's performance on a scale of consistent to inconsistent against what they just learned. And I might add that we think that this is far superior to CAP surveys or health grades, because now you have a discriminating, knowledgeable patient being asked an objective question based upon a disease-specific performance against an evidence-based standard. And when the patient completes these 6 easy steps, they earn typically $15 for completing the information therapy session. And the system provides all the necessary tax reporting requirements. And I want to emphasize again the fact that these 4 steps are first in medical history. Believe it or not, no one has ever routinely assessed a person's knowledge, asked them to declare their adherence, asked them to allow them to rate their doctor's performance, or to take a discriminating, knowledgeable patient and ask them how the doctors perform. Some more about the program is that it bolts on to any health insurance plan. It can bolt on to a worksite clinic if the clinic might be held accountable for economic or health outcomes. Once it's implemented, the plan sponsor, insurer or clinic arranges for member eligibility files to be transmitted to the program's computer on at least a monthly basis, and replicate claims on a daily basis. So every day the program is receiving claims data, typically before they are adjudicated, transmitted again electronically. And from this data at launch, patients receive an orientation letter that includes a membership card, and they're informed that they are covered by this new benefit and that they don't need to do anything until they have a rewardable event. Again, a rewardable event heretofore has been an office visit. And when the patient has an office visit, they are then notified at home about their opportunity to earn a reward. And the doctors are also notified actually before the patient. And while doctors' inclusion is essential, patients need to know that their doctors are being given this opportunity to participate. What we found is that patients' participation is much more important in terms of achieving the desired results. And then the final instruction is that even though a doctor and a patient may be, plan member may be enrolled, their participation in the program is voluntary on an office visit by office visit basis. So I mentioned earlier that I would explain what happens when a doctor doesn't participate. And this flow diagram shows when a doctor does. So a covered patient visits the doctor chooses to participate. He or she then supplies the system either directly through the internet or through their electronic health record, or simply filing an insurance claim. Eventually the program gets the diagnoses, the office visit event, and tees up a list of articles in relevancy order to the diagnoses, and the doctor selects one as homework, information therapy prescription. And then that is automatically transmitted to the patient, at which time the doctor earns his or her reward. And the patient chooses to respond to that information therapy prescription and read the prescribed article, then they also earn a financial reward. If the doctor does not participate, he or she files the claim. We send a notice to the doctor. The doctor is given 4 days to respond to that notice. If he or she chooses not to, then the program sends the notification to the patient. And in that notification, the system uses the diagnoses from the claim form to tee up the articles, and again, relevancy order, and the patient is free to select their own article. So that's how it works, and it works quite well either which way. This is a very science-based, fact-driven solution. It has been subjected to numerous studies. Because the outcomes are so extraordinary, we find ourselves being pressed into conducting studies pre-post. We've had several of those, some of which have been conducted by very reputable, well-known provider organizations. And we've had 2 randomized control trials, one with the state of Oklahoma, and more recently with the Wisconsin Physician Services Health Insurance Company. And that's the one that I'm going to share with you in just a minute. The pre-post studies have been certified by the Validation Institute, if you're familiar with them, founded by GE and Intel to separate fact from fiction in this world of healthcare innovation. And the program was identified as one of the first, if not only, innovations to have peer-reviewed and certified proof of solving the quadruple aim. And then the Validation Institute has taken it a step further. They will financially guarantee any customer that adopts the program that it will in fact solve the quadruple aim. And then more recently, the Society of Actuaries and the Kaiser Family Foundation read the studies and selected the program as one of the most promising innovations to solve their Initiative 1811, which is an attempt to lower the country's healthcare spend from 18% of GDP down to 11%. And we're very proud of that. So, in terms of breaking news, we have been conducting a randomized control trial with the Wisconsin Physician Health Insurance Company, in which they divided their health plan into 2 populations. The 2 that were covered by the program were located in Illinois and Nebraska against the control population in Wisconsin. We employed a difference in differences statistical method and control for all known variables to create an apples to apples comparison. And what I'm going to share with you is how the covered population compared to the non-covered population against 2 years of baseline. So 2 years of claims data prior to implementation against the first year after implementing the program, the covered population versus the non-covered population. And the first thing that I'm going to report is that medication utilization, medication adherence increased by 22% in the covered population compared to the control, as expected. So when behavior changes, when behavior improves, we see an improvement or an increase in medication adherence. We also saw an increase in office visits as expected, a 7% increase. This caused a dramatic over 50% drop in hospitalizations in the covered population against the control. We also saw a 5% reduction in emergency room visits. This in turn produced nearly a 19% net savings and a better than 10-to-1 ROI. So we're in the process now of reanalyzing, revalidating these results because they border on the unbelievable. And so to do that, we are engaged in what we call a sniff test. But before I share that with you, I want to show you the pharmacy trend and the hospitalization trend to try to put this in perspective. The red trend line is the non-covered population. The green trend line is the covered population. And pharmacy is on the left. And you can see that the trend for both groups were almost parallel prior to the dotted line, which is when the program was implemented. So the 2 years prior, both groups were trending in concert. And then the program was introduced and we saw this dramatic difference in hospitalization, in pharmacy rate. And then on the right side is hospitalizations. Again, the groups are trending in a parallel fashion. And then, and that kind of illustrates what happened during COVID. And then we had the controlled population, the non-covered population experienced the typical V nationwide. We saw a rebound in hospitalizations as the pandemic eased, but that didn't happen in the covered population. Its hospitalizations continued to drop and drop dramatically. So in this sniff test, what we did is we made sure that maternity and accident admissions were removed as non-related to the program, and we discovered the following. We drilled down to examine what diagnoses were most impacted that caused this big difference between these two groups. And in the top 5, we noticed circulatory systems dramatically higher. A dramatic difference in circulatory diseases. Also health status factors, all the Z codes in the ICD-10 book, and mental and behavioral disorders, all of which are behavior related. The next thing that we discovered is that the 2 most frequently read articles by participants happen to be for anxiety and high blood pressure, correlating to the impacted diagnosis categories. And then the third thing that we discovered was really interesting. We noted that, as I mentioned earlier, office visits increased as expected. And so we expected lab orders to move in the same direction, but they in fact decreased as office visits increased. And we couldn't quite understand what that was all about. And then we did the same thing as we did with hospitalizations with lab orders, and we examined the diagnoses that were most impacted, and far and away the one that was most impacted were the Z codes, the factors that influence health status, the very ones that you would expect if we are in fact nudging an improvement in health behavior. And to give you some sense of how dramatic this was, here again we have the 2 groups trending in the same direction prior to implementation. And then the program was implemented. The control group continued to increase in terms of lab orders related to health factors influencing health status, but the covered population saw a dramatic decrease. Another thing that is noteworthy is the fact that our last 2 customers were added as a result of discounts they received through their stop loss insurer that essentially pay for the program. I'm going to ask my colleague Jim Dempster, who's principally responsible for this relationship with stop loss insurers, to comment on this development. Jim?
Thanks, Jeff. For years, leading stop loss companies have recognized the risk mitigation features found in the MedIncentive program You look there on the right, you'll see what some of the top companies like Sun Life and Chartis, AIG, I'm sorry, on the left, have put, set their prices at. They've been much more aggressive with their stop loss prices for employers who include med incentive as part of their strategy to improve health and control costs. On the right side now, Companion Life's subsidiary ISI is just the latest stop loss carrier, and their discounts, as Jeff said, cover the costs of our program. And I expect the results from this latest study with WPS will cause more stop loss carriers to discount their costs even more. So let us know if you want help with your current stop loss carriers or find lower cost coverage for catastrophes in the future.
Thanks, Jim. Okay, so why does it work? I've listed 12 reasons I think that are very important to delineate. The first is that paying doctors to prescribe information therapy honors their time and places a therapeutic value on health literacy, which study after study has established as the single strongest determinant of a person's health status, life expectancy, and cost. Next, if doctors fail to participate, the program is designed to make sure that the patient is not deprived of their opportunity, as I explained. The program offers a financial incentive to patients for doing something easily attainable and non-discriminatory. Patients have the opportunity to learn and reflect on their commitment away from the stress of the doctor's office. It works because documenting patients' knowledge and adherence with each encounter closes these feedback loops that I was describing earlier. It employs financial incentives, again, to tap into the doctor-patient relationship, to invoke these industrial psychology, psychosocial motivators to empower patients to better health, such as the promise-keeping guilt aversion, such as the Hawthorne effect. It works because physicians are more fairly evaluated by a learned, discriminating patient who must first demonstrate that they understand the evidence-based care. Program promotes health equity. I know this is an important initiative for many organizations because it empowers and dignifies people, no matter their social economic status. The program is scalable, it's fast acting, it's sustainable. So it doesn't just do 1 year, then eventually things deteriorate. It's easy to implement and maintain, it's inexpensive, and it is very popular with plan members and doctors. Thousands and thousands of testimonials. And finally, the program is proven effective to improve health and lower cost. So real quick, the pricing structure is fairly simple. The administrative fee is $3.50 per member per month. Depending on participation rate, the patient rewards and the physician compensation work out to somewhere around $4 per member per month. So the total cost is something less than $100 per person per year. In this example, $90. And it produces these gigantic return on investment. And to put this in perspective, the most recent Business Group on Health Fidelity Investments survey of US corporations places the investment that these firms make in wellness programs somewhere between $600 and $800 a year, which is 6 to 8 times more than the entire cost, including patient rewards, physician compensation, and administrative fees for the program. So in terms of how this program relates to worksite clinics, well, certainly educating and motivating, empowering patients by tapping into that doctor-patient relationship is very complementary to worksite clinics. In the current tight labor market, a benefit like the program is a differentiator that can help attract and retain personnel. And we hear this more and more. And finally, every employer and worksite clinic provider would benefit from a proven and guaranteed means to control cost, especially if those relationships involve risk sharing arrangements. So here's a list of studies that are referenced in the slide deck for those who might be interested. So I'm opening up to any questions that you might have, and I'm anxious to get your feedback.
Great, thank you very much, Jeff. Very interesting, and congratulations on the findings of the results. What I'm going to do is, as we regularly have done, is to go around the table and ask people for specific questions or experiences or comments relating to that. But I'll just start off with one of my own. You know, many of our populations have multilingual, multicultural populations. Is this program set up to provide information in a language that people can understand, or are there certain options on this?
Yes, the content and the program comes out of the box in English and Spanish. And then for other languages, we recommend Google Interp that can help in conveying the information that the patient needs to know.
Mm-hmm. Okay, and secondly, you know, many people are afraid to question their doctor, and the portion where a patient grades essentially whether the doctor's adhering, how does that actually work? What does it look like?
Well, first of all, it's in the privacy of your home. And it allows the patient to be discerning in their response. And it is not so much, do you like your doctor? It's more about you just learn something about what you're supposed to do and what your doctor's supposed to do for your particular medical condition on a scale of consistent to inconsistent. How did the doctor perform? And we grade those, and we have, you know, we're a repository of a tremendous amount of data responses. And we also get often, what do we do with those responses? Well, to date, we've not done anything, but we are committed to this philosophy, and that is that the medical community will learn of the champions. We want people to know the top-rated doctors, and we do not want the low-rated doctors to be ridiculed without due process. So we wouldn't share that with anyone until those doctors get a chance to examine the responses and decide how they want to perhaps change their approach. So we are big believers in the golden rule and making sure that we put ourselves in each of the stakeholders' shoes. And that's what makes it so effective, is that we think about this from the doctor, the patient, and the insurer's point of view.
So again, in our environment, among our membership, you have employed physicians, employed nurse practitioners, PAs who are leading these centers, and they're on salary. So many of the centers, virtually all of them, do satisfaction ratings of the providers, and they ask the patients who use the centers to submit those their reactions and their experiences. So could it be set up so that the patient's findings on the clinician that is to have sent them the information and followed it up, could that be sent back to the employer and their service provider partner?
If we're asked, absolutely. Yes, indeed.
Great. All right, let's go around the table, and I'll make sure I unmute you all. So again, as I can identify you, Alex Jordan from Health Partners. Alex, questions, comments?
Great presentation. No questions or comments at this time. Thanks.
And then we have someone who's identified as C13078. I assume you're not a computer, so do you have a comment, a question, and identify yourself?
My name is Susan Coggins, and I'm a nurse practitioner. And my only question was, what's the average length of each of the information therapy prescription programs?
Do you mean for the patient?
Yes.
Well, it depends on the diagnoses. A wellness article may be pretty short, may not take very much time at all. Whereas a article on diabetes, really the content is expansive, and there's most of these articles contain links. So we find patients that are really in pain and are fearful, drilling down into sites like HealthWise and learning as much as they possibly can. And in those instances, it could take, 20, 30 minutes, depending upon how much information they choose to read.
Thank you.
Thanks very much. Carl from Lehigh Valley. Questions, comments, Carl?
Great discussion. Nothing, Larry. Thanks.
Okay. Ed McNamara from Premise. Comments or questions, Ed? Reactions? Ed, any comments or questions? Okay. We have someone again identified as JCGRE. Any comments or questions? Identify yourself. No?
Yes, this is Jess Green. I'm actually employed with Med Incentive. And
Okay.
I
Fair
hope
enough.
you can hear me. I've had trouble with my microphone and camera all morning.
Sorry about that. Well, this has been recorded, so we'll make it available to you again. Ed McNamara. Ed, any comments or questions? No. Okay, Ray Cassambla from Pfizer. Any comments or questions, Ray? Sorry. Had you on mute. Go ahead. Ray, any comments or questions?
Yeah, hi. Can you hear me now?
Yeah, go ahead.
Great. Yeah, so first, thank you for the presentation and Larry for including me. Question, how does this bump up against the concept of advanced primary care? I'll stop there.
Advanced primary care. Tell me more. I'm not sure if I'm familiar with that.
Yeah, so, advanced primary care, it's not quite ubiquitous yet. However, there's this concept of moving beyond a patient-centered medical home to include mental health and other things that are not contemplated within PCMH. And I recently had a discussion, and I think it intersected into this, where they were talking about increasing resources to include pay to primary care doctors in order to, give them more time and build a better patient experience. And the idea is, if you build a better primary care experience, patients will start going more so into primary care doctors. And as we all know, many people don't even have a PCP. So where the financials, in my mind, intersected, where increased pay to primary care, is a commonality. I thought you might have some comments around that. Thank you.
Well, we wouldn't dissuade anybody from continuing to re-engineer the care, of the delivery of care, or fight battles over pricing. We think that those efforts will continue. The missing element, the distinction, is about how the patient is empowered. And we recently discovered a study, of meta-analysis of studies that have to do with empowerment, medication adherence, the locus of control, which supports the concepts that I've just presented to you, that the objective is to provide the patient what resources, what knowledge that they need in order to self-manage their health, with the doctor standing by as their expert resource to help them when they exceed what they know or they feel capable of managing. And we think that that's a very important concept. And it works. I mean, it has worked for years now. And that's what we know.
That's great. So Jeff, if someone wants to explore this further or perhaps even contract for this, how do they get information? Who do they reach out to? Do you have is there something on the slide?
Well, here on the slide is Jim's contact information, jdempster@medincentive.com.
And how long does it take to implement something like this?
Well, the only really moving part, I mean, it's not labor intensive, it's very scalable and simple. The only moving part is that electronic data exchange that takes place between the plan sponsor and the program's computer system. And it's designed to use industry standards, 831s, 827s, or what they're called, to transfer eligibility and claims data seamlessly. But sometimes we run across third-party administrators or health insurers. It seems like the larger, the more difficult, that have a struggle getting those transmissions established. So if the plan administrator is ready and willing, it can take as little as a week. If they are not, we have seen installations take as long as 6 months. But once we get the eligibility, I mean, it's all automated, completely automated. I mean, we're really proud of how we've constructed the program to send out notices of coverage notification. We put the plan sponsor's logo on our communications so they know who's underwriting this benefit. And that happens automatically. And then when the office events occur, if we have that data exchange established, we're receiving claims data, and we know when office visits occur, and then the notification to the patient and the doctor occur automatically. I mean, as we speak, it's functioning flawlessly, quietly, and effectively.
And how are the payments handled? How does someone actually receive the payment? And how does the provider receive the payment?
Well, heretofore, we think that the strongest reinforcement is kind of a lesson in Pavlovian conditioning, is a check in hand, something that a person is rewarded shortly after a good deed with something of value that they can see, touch, smell, and deposit. Mm-hmm. So we send a claim. It has the same format as any other claim, and in some instances it is for a therapeutic agent, if you will, information therapy, and it has a HCPCS code that is recognized once we set up the relationship with the plan administrator, and they automatically cut the check.
So the check is made by the employer then, or in our case, or it could be the clinic partner, vendor partner.
Could be.
Okay.
Often it's farmed out to their plan administrator. So, for instance, Aetna has done it. United has done it. We have other TPAs that perform that function. If the third-party administrator can't do it or won't do it, then we have the capacity to do that. We set up a escrow account that the plan sponsor funds, and we can cut checks on a daily basis and send them out. So there's lots of ways that the rewards are transmitted. Mm-hmm. Now, we have had a great bit of interest in the Medicaid population. And in Michigan, there was a statute passed to mandate the testing of the program. And in those instances, we'll probably switch not to cash, but to expanded cell phone coverage. Medicaid patients receive a lifeline cell phone with limited talk, text, and data. We've proposed that if they complete their information therapy prescription, that coverage would be expanded. So that's just to give you some idea that there's a lot of flexibility that could be applied to the reward.
Okay. And under the requirements relating to incentives for wellness programs, there's always some concern about giving people money And then, do they need to be taxed on this? Is this considered a wellness incentive? Have you looked at the legal aspect on this?
Yes, we've examined this closely, and today it is a wellness reward, so it would be considered taxable. So we send a report, or the TPA sends a report to the employer to affect the patient's pay on a quarterly basis, if not more frequently. But we also know that Medicare, Medicaid, CMMI, their innovation, has introduced models where patients are now receiving checks, financial rewards that are not taxed, not considered income, because it's considered therapy. So it's a little bit different than a wellness program in that this is a therapeutic agent. And so we've asked, and CMS is very familiar with our program. They're anxious to, by the way, to see the WPS randomized control trial. And we think that will prompt a Medicare demonstration, hopefully in not too distant future. But they have been corresponding with us, giving us some guidance on what constitutes a non-taxable financial reward in their direct contracting and ACO models. So today, if you're a provider, you sign up for direct contract and ACO, they can make a up to $20 cash reward payment to a patient, tax-free.
Okay, thank you. All right, before we conclude, let me again go around the table and see if there's any final questions. Susan Coggins, any final questions from you?
No.
Okay, Alex, Jordan, any comments, questions?
No, thank you.
All right, Carl Kaufsitz, any other comments, questions?
Oh, thanks, Larry.
All right, Ed McNamara, any comments or questions?
Nope.
Okay, Ray, any comments or questions?
No, Larry, thank you.
All right, well, everyone, have a good, safe week. Hopefully you'll join us in our April program on behavioral health. Otherwise, have a safe and enjoyable week. Thank you again, Jeff and Jim. Talk to you later.
Thank you. Bye-bye.
Bye-bye.